from the various facilities who have recovered from the coronavirus disease. This brings the total number of recoveries to 1,048. We shall be failing if we do not recognize the good work of our healthcare workers, whose effort and dedication has made it possible to record these many recoveries. I urge you to join me in appreciating our healthcare workers for this wonderful achievement. Regarding the statistics of cases in the last 24 hours, we have recorded 105 positive cases from a sample of 2,273 tested over the last 24 hours, which brings the total number of confirmed positive cases to 3,094 from 102,956 samples tested so far. So we, as said yesterday, we have already crossed the 3,000 mark. Out of today's cases, 96 are Kenyans and 9 are foreigners. 77 are males and 28 are females. The youngest is 2, the oldest is 77. These cases are distributed in the following counties: Nairobi with 43, Busia with 18, Mombasa with 11, Turkana 7, Migori 6, Kwale and Kiambu 5 each, Kilifi, Machakos and Taita Taveta 3 cases each, Kisumu 2, Uasin Gishu, Siaya, Kajiado and Garissa 1 case each. By sub-counties, in Nairobi, the cases are from the following sub-counties: Ruaraka 14, Langata 5, Dagoretti North and Kamkunji 4 each, Embakasi West, Embakasi East and Kibra 3 cases each, Starehe and Westlands 2 cases each, Makadara, Mathare and Embakasi South 1 case each. In Busia, all the 18 cases are truck drivers at the Malaba border point. In Mombasa, the 11 cases are from Kisauni 5, Likoni 4 and Mvita 2. In Turkana, all 7 cases are of truck drivers at the Nadapal point of entry. In Migori, the 6 cases are from Kuria West 4, Nyatike and Suna East 1 each, while in Kiambu, the 5 cases are from Ruiru 2, Kiambu Town, Juja and Lari 1 case each. In Kilifi, all the 3 cases are from Rabai. In Machakos, all the 3 cases are from Athi River, while in Taita Taveta, all the 3 cases are of truck drivers at Taveta border point. In Kisumu, the 2 cases again are of truck drivers in Kisumu Central, while in Uasin Gishu, the 1 case is also a truck driver in Tarbo. In Siaya, the 1 case is from Rarieda. In Garissa, the 1 case is from Dadaab. And in Kajiado, the 1 case is from Kajiado East. Of course, we now and then are saddened when we lose a patient. And today, we have lost another one patient to the disease, bringing the tally of deaths to 89. The patient was in Nairobi in one of the hospitals here. I send my heartfelt condolences to the family of the departed. As you will note, we are seeing more and more truck drivers turning positive, and the issue of truck drivers at the various border points, particularly the border points with the Uganda border at Busia and Malaba, have remained of great concern to us. And as a ministry, we are working very closely with the county government of Busia to provide them with the support and necessary support that they may need for us to jointly address the situation there. Fellow Kenyans, let me now say a few things about home-based isolation and care that we have talked about before. While the World Health Organization recommends that all laboratory-confirmed cases of COVID-19 be isolated and cared for in a healthcare facility, it also recognizes that not all cases can be cared for in a health facility when the numbers begin to rise, and that prioritization of hospitalization and alternate care systems need to be explored and considered. As you are aware, due to our rising numbers of COVID-19 cases, it is increasingly becoming untenable to isolate all patients in our health facilities for management and care. We are glad to inform you that today we are launching our home-based isolation and care guidelines for patients with COVID-19. This guideline is available on the Ministry of Health website, and I encourage you to look at it, download it, and look at it so to get a clear understanding of what it entails. This protocol has been developed to provide a solution in the management of the increasing numbers and the anticipated surge in COVID-19 cases. Currently, according to the available data that we have, 78% of infected persons, that is, positive cases, admitted in our hospitals are either asymptomatic or mildly symptomatic, and therefore can be managed at home, provided proper laid down procedures are followed. The home-based isolation and care guidelines dictates these procedures. The guidelines expound on key areas that include eligibility, care procedures, medical monitoring, referral system to health facilities when the need arises, criteria for determining recovery, and community participation, among others. The implementation of the guidelines shall be done under the supervision of medical and public health officials. Community health volunteers will be involved in the daily assessment of home-based patients and will be the key link between healthcare workers and the households. Home-based care in informal settlements, where households share small spaces, will require identification of institutions within the community, institutions that meet the recommendations for providing such care. And we are working on identifying such institutions within the community where such home-based care can be provided. And herein, we will also be drawing upon the Nyumba Kumi initiative in such settings, for they certainly have a role to play in supporting the care in the community. To succeed, the Ministry of Health appeals to non-governmental organizations, for they are very much involved and work at the community level, as well as others and well-wishers to partner with us in this fight against COVID-19. Implementation of these guidelines begins immediately. I therefore urge all stakeholders involved in the care of COVID-19 patients to adhere to these guidelines and ensure that it cascades to all informal caregivers of these patients in order to ensure delivery of quality services to our citizens. In conclusion, I want to restate that every effort be made to contain, stop, and reduce the transmission of the virus in our country at all costs. Thank you.
Thank you so much. My name is David Mudhoka from TV47. My question touches on the truck drivers, especially at Busia, where the numbers are plummeting each day. What is the situation there on matters, the quarantine facilities, isolation facilities? Is the county overwhelmed by the numbers? Thank you.
Thank you so much, Seth Olale, NTV. Just two quick ones. In terms of the number of health workers, is it directly proportional to the need at hand? That is the 78% of infected patients. Do we have capacity in terms of healthcare personnel? My second question is about the Lancet versus some of private hospitals in this country. We saw a variation in terms of test result for COVID patients who went to Lancet and the result differed from another in Nairobi hospital. As Ministry of Health, who is supposed to be the authority here? Thank you.
My name is Purity Muse from KBC. When you look at other nations, for instance, China or US, when the first case of corona was reported and 3 months on, then the countries were experiencing serious symptoms of coronavirus. But we are getting or almost hitting the third month, and most cases, as you said, are asymptomatic. Is this the case, or do we expect the symptoms probably to be serious because most Kenyans are asymptomatic? Do we expect the symptoms to get serious, or this is the kind of COVID-19 that we have? And on the truck drivers, most numbers today were coming from truck drivers. Are they getting this virus locally or importing, getting from other countries? And what are you doing as a ministry, as the ministry, to stop this spread, especially infection among the truck drivers?
My name is Chomtai Goin from Citizen TV. When you've mentioned that you are starting the immediate implementation of the home-based care protocol, how many patients, if any, do you have under this program as you commence it? And maybe just expound on the fact that for those families that could not afford spaces that they can hold the patients that are there, what measures are you putting in place? And the second one, on truck drivers, there are protocols that you had outlined on where like truck drivers would have stopping, designated stops. Are you trying to manage those areas to ensure that they do not even spread to those particular areas that they are stopping in case of Namanga and Malaba and all the other areas?
Okay, yeah, thank you. David Mutoka, your question was regarding the truck drivers at Busia, the increasing numbers and whether we have capacity there to be able to manage them in quarantine or isolation. I think in my presentation I talked about that as being one of the challenges that we are facing in Busia, and health being a devolved system and the county being responsible for that function, we find it necessary that it's important that the national government works with the county to be able to boost its capacity to do this. particularly for those counties where on the border where there are corridors that go through them. We shall work very closely with those counties to build their capacity and also to address this issue where we have, as I mentioned yesterday, the snarl up of trucks, because these themselves create a very high-risk situation which we do not want to have. So we are working with them. Perhaps when I give a chance to Dr. Kuria, he may talk a little bit more about the issue of truck drivers. Seth, you asked about whether we have the adequate capacity of health workers to cope with the number of cases that we are seeing. Now, you know what I said is that, and the whole idea about home-based care is because of the particular situation we are experiencing here. I think it was, this also will answer to Purity's question, where she asks about what we are observing here seems to be different from other places. We have said that when we pick up positive cases, anytime a person is confirmed to be positive by laboratory testing, that's what we call a confirmed or a positive case. Yes? Yeah. They are on that side, but I will try to face you. It's called a positive case. So that positive case, under normal circumstances, you will place that positive case in isolation. Well, what we are seeing is that 78% of the positive cases that we pick are actually asymptomatic, meaning they just do not display any symptoms, they do not appear to be sick, yet we know that they have a virus. And either asymptomatic or very mildly symptomatic, so that the symptoms may be just like something like a flu that, you don't need to be hospitalized, you will get over it in time. Given this observation that we have this kind of a number of patients who really do not need to be occupying a bed in a health facility, is the reason why we have looked at the possibility of home-based care. And these guidelines that we have talked about are able to ensure that if we put them in home-based care, we still are able to maintain and contain that person so that they do not spread the infection. That's what the guidelines are all about, to make sure that if you put them there in their homes or in a community setting, that you will still be able to eliminate the transmission of virus from that individual to others. So in a way, it is a good thing for us to do this, because then we will also, you do not need any specialized healthcare workers to take care of these individuals, because they can be taken care of within their homes by home carers, members of the family whom you can designate as home carers, who will be properly trained and equipped with the equipment and will follow those guidelines. It frees up our healthcare workers who will be required in facilities to take care of those who actually require more care. So in that sense, I think it is a positive thing. It will free up our healthcare workers. We can utilize those healthcare workers for some of the more serious cases that are required there, given that we already have a deficit in healthcare workers within our facilities, not only for COVID, but in general to provide medical care. Then the second question that you followed up with was this issue of what I would call the quality issue in testing. The issue of quality and ensuring that quality is maintained is a function of the ministry and our regulatory authorities. Quality of services is part of our function, and we are supposed to ensure that this quality is in place. As I had mentioned a couple of days ago, we have a protocol for determining the level of quality that the various laboratories provide. In fact, our approval of such facilities to be able to conduct these tests is based on a series of assessments of their capacity to be able to produce quality results repeatedly. So where such situations do arise, we will move in and we will administer the type of quality assurance tests that we do to make sure that the services being provided are of the right quality. The tests coming out of these facilities are the correct tests. So we do address this, and we are addressing any discordancies that we see. At the same time, recognizing the complexities of the particular test that we are working with in conditions where they can fail or produce a false positive or a false negative result. But the determination will be made by the ministry, and corrective measures those institutions will be required to put in the right corrective measures in order to continue to enjoy the approval that they have from the ministry to conduct these tests. Purity of KBC, I think I have answered that part on the kind of trajectory we are seeing in largely in Africa, where a good number of our patients are asymptomatic. It is an observation, and which is slightly different from what has been seen in other countries. In those countries that you mentioned, you can see that within about 2 months or so of their first cases, they were really hitting very large numbers of people who required critical care, and hence their systems were overwhelmed. Now, whether we are still at a low level of our curve, and we may reach that curve, we cannot say for sure right now. We'll just have to wait and see. But we do hope that this pattern is a different pattern that is not, as demanding in terms of care than what we have seen in other countries. It's also dangerous to live in a comfort of something that you don't know how it will turn out. So we do not want to take any chances and think that because we are seeing this, that we are safe, in a better place than others. No, we do not know where we are on this curve. Tomorrow there could be a huge surge. And by the way, we have seen, cases have been seen where people are asymptomatic, but they can very quickly progress into serious clinical conditions. Such cases have been recorded. So we need to be prepared for the worst. And I think that's the approach that we are taking. You asked also about the truck drivers, that we are seeing increasing numbers of positive cases among truck drivers. I think your question was, are these truck drivers importing this from other places, or is it local transmission? Well, I think if you look at our truck drivers that may be coming from, who are going out of the country, say on the northern corridor, from Mombasa, Nairobi, taking their cargo across and then being found positive at the border, I would say that that is probably local transmission within the country, because they are within the country wanting to move out. But when we do get drivers who are coming into the country from another country, in that case we can say that those, if they turn out positive, those are likely to be imported cases. And of course we don't allow. At any rate, if we are able to determine at the border point, for example at Namanga, where we have the functional lab there, when we test drivers, whether Kenyan or Tanzanian who are coming into the country, if they turn out positive, then we do not allow the foreign drivers to come in. But of course, the Kenyan drivers will come in and will be given the right kind of treatment, that is isolation, will be placed in isolation. So largely, now we have the virus in our neighboring countries. The virus is circulating in Tanzania, it is circulating in Uganda, it is circulating in Somalia. So, if you look at it as a region, it's there. So we have transmission within the region, so to speak. Okay? Chemtai, how many patients are asymptomatic, and how many patients are we going to put into this program of home-based care? As I said again, because of the nature of infections we see being asymptomatic, I think, of course, priority will be to take those who are lowest risk into home-based care if those criteria that are laid out in the home-based care guidelines are met. And it will be on a case-by-case basis that will be determined, because when you look at the guidelines, you will see what is required. The facility where the household where the patient will be kept will need to be looked at, and the measures that are required will have to be in place. So it will be done on a case-by-case basis. In terms of those where, say, we talked about community-based facility, where we can place some of these asymptomatic patients within the community, but in a facility where they can be cared for and observed. That I would imagine those who cannot pay from the informal settlements, when we do identify these institutions and set them up, I think it would be an obligation of the state to be able to meet those costs of keeping them there. I think that was it. And
my name is Graham Kajilo from the Standard. My question is related to a study that was published by Harvard University that claimed that the virus was already circulating in China before the first case was reported in December. In our Kenyan context, that we've seen a lot of community infection, I would like to find out to what extent have you done the surveillance of the disease in the country in order for us to, probably to justify that the disease was already here before the first case was discovered in March 12th.
Na waziri, naitwa Haemba kutoka Ebro. Naomba tu kujua mataifa ambayo yameweza kukumbatia mfumo wa wagonjwa wa virusi vya corona kuweza kutibiwa nyumbani, mataifa ni mangapi na ni yapi hasa? Alafu labda katika Afrika, je, ni Kenya ambayo itakuwa labda taifa la kwanza? Alafu swala lingine ni kuhusiana na vyeti na barua zinazo
taifa la kwanza kufanya nini?
Labda kujiunga barani Afrika, labda Kenya itakuwa ya kwanza labda kukumbatia mfumo huu wa wagonjwa wa COVID-19 kutibiwa nyumbani. Alafu swala lingine ni barua na vyeti vinavyotolewa kwa madereva na hata wananchi wengine wanaovuka labda nje ya Nairobi na hata Mombasa. Wengi inadaiwa kwamba baadhi ya barua hizo ni gushi. Je, labda kama serikali labda maafisa wa polisi katika mipaka watajua vipi ya kwamba hiki cheti ni halali?
Jimmy Mbogo from K24. Now, a couple of questions. Number one, with regards to the active cases that are currently in hospital, how many do we have that are in critical condition, and do they have underlying medical condition, or what is the pattern that you're currently seeing? And the other issue is with regards to the border points. We understand that there's a system failure from the Ugandan side. Are you working with your partners, for instance, the Ministry of Transport, to sort of clear this, or to understand what are the other issues? And lastly, just a follow-up with regards to the budget being read tomorrow. We understand that the ministry is likely to get over 100 billion shillings coming in to be able to help in this fight. We've seen a lot of money being taken to counties, yet the medical facilities in counties still remain in deplorable condition. What are you doing to follow up with counties and ensuring that this money that is being given to them is directed or channeled to those medical facilities?
Okay, thank you. I'll tackle some of those questions. Others, I think I will have my colleagues here handle it. There was a question regarding the virus. You talked about a publication. I didn't catch which publication, but I think I got the essence of your question was really, can we tell whether this virus was already with us before the first case on the 13th of March. My answer to that would be, if you look at the origin of this initially epidemic, which became a pandemic, we all know that where it started, and we know how it spread quickly to many other places. And the timeline that we know of, this thing began in China in around December, for the whole month of December. It was towards the end of December, in January, that the world became aware and WHO became aware of this virus. And a month is a long time in terms of the global nature of things these days, particularly in terms of travel, where people could have easily traveled to different places in this world, people who are potentially infected, and spread it. The way to be able to determine that kind of tracing back, there are ways of doing that. One is doing genetic studies by looking at the viruses that are circulating in a particular country. You can look at the sequences of those viruses, and then you can be able to relate these isolates, to the sequences of isolates in other places. So if you find that there are isolates that were circulating, for example, in Wuhan during that time that the pandemic broke out, and you're able to relate to some that may be present in your own area and community, there are methodologies that you can use to be able to develop relationships, or what is called genetic trees, that might be able to answer this question. And we do know that our Kenya Medical Research Institute has actually been doing part of this work at Kilifi. Let's wait and see. As the body of this work increases, we may be able to get an answer about when this virus might actually have come into the country, okay, if that was the case. Home-based care. Will we be the first country that is implementing, at least in Africa, this home-based care? I really don't know, but I do think that indeed we could be one of the first countries that is considering this home-based care approach. I'm sure that many other countries who are being ravaged by this are possibly looking at it. I'm not sure about Nigeria. I don't know if you're aware of anything happening there in home-based care. Are they doing it? And Ghana as well, huh? Yes. So at least I know in the developed world that has been done, because the living conditions are there. It is very possible to do it. But in Africa, there are countries that whose numbers are much higher than ours. For example, if you look at Nigeria, look at Cameroon, look at South Africa, their numbers are much, much higher than ours. And I believe that they are probably doing home-based care there too. So for every country, a time comes when you have to be a little bit pragmatic and say, yes, I'll put in the right measures, but can I relieve my health systems from this pressure if I can maintain people who are not that sick, but who nonetheless can transmit the virus? If I can maintain them in a controlled condition within their homes, I will be able to free up my health systems. So that is really the logic of it. And I think many more countries will probably be adopting this approach as we move forward and the numbers rise. Somebody from K24 asked whether we have data that breaks down our patients who are in facilities right now in terms of those that are critical, those that may be severe on intubation, and so on. We have that data. We actually generate reports, daily reports, that give a breakdown of this. I do not know what the current breakdown is, but that information is available. On a daily basis, we have these reports that tell us where the patients are, how many are in what state, critical or severe, as well as the clinical clinical background of some of these patients. Generally, what we have seen is that most of the patients, even in our own setting, as has been observed globally, even in our own setting, most of those patients who progress to become severe and sometimes even critical tend to be, number one, older patients, two, have some other comorbidities that they may have. And generally, you know that the older you grow, non-communicable diseases, you will also have one form or the other of non-communicable disease, either a cardiovascular condition, maybe diabetes, maybe some other condition. So that predisposes you. And indeed, we do see that those of our patients who have progressed and some of them that who have passed on actually fall into those two categories, age and underlying conditions. However, it doesn't mean that young people do not also progress. We have seen a number of cases, fairly young people who very quickly move into severe cases, and some of them have even passed on. I think we have reported now and then cases of people who are 30 years old or so who are dying, and this is seen in other places in the world as well. Then there was a question about the situation at the border regarding the trucks and what we are doing about this. We are engaging fully, and there are several ministries that are involved in this, because when we talk about trade, the trade ministry is involved. When we talk about the corridors, the northern corridor, cargo crossing borders that are serving neighboring countries and countries beyond, we are talking about the East African community. We are talking about the Ministry of East African Cooperation. We are talking about the Ministry of Transport. And we, as a government, represented through all these three ministries, are engaging through the East African Community Forum ways of trying to address this movement of trucks and cargoes. The system failure that you said happened in Uganda, I'm not sure whether it has been corrected now or not, but those kind of things, of course, create snarl-ups. But the protocols that we have put in place, and particularly if we are able to implement the protocol of prior testing of truck drivers before they embark on their journey, we should be able to ease the movement of trucks across borders. Let me now call in Dr. Kuria, perhaps to add on to that and maybe respond to any of the questions that came up that I did not respond to, especially on the truckers.
Thank you, Kasser Rashid. Indeed, the issue of truck drivers has been thorn in the flesh in this country for the last 2 to 3 weeks. And since we launched the protocols that control the movement of truck drivers along the transport corridor, we've seen failures in the system on our part, but largely on the part of the truck owners and the truck drivers. The problem we are experiencing at the Malaba-Busia border is largely a making of the truck drivers and the truck owners. Because our protocols state clearly that you need to have your test taken 48 hours before travel, and you are issued with an attestation of testing. So far, most of the drivers that have appeared at the Busia-Malaba border have appeared there without a certificate, or even without testing. Maybe it's just how Kenyan we are, because that is defiance, so to say. And as I said, Monday, yesterday, we deployed a team of laboratory technicians and port health officers to Malaba to try and clear the snarl up of vehicles and trucks in Busia and Malaba. We have managed, as I said yesterday, to clear much of that backlog and reducing the jam of the snarl up from 74 kilometers to about 19 as we speak. What was on a double lane is now a single lane in Malaba. And you've talked about a system failure on the Ugandan side. That was due to a power failure in Uganda and has been sorted out. And where it seemed to have been slowed down further, I think, as the CAS has said, we engaged the two counterparts on either side, Uganda and Kenya, and the revenue authorities engaged, and this was sorted out fairly fast, and it is back to normal. So our plea to truck drivers too is to ensure that before you start your journey, you have your test taken, and then only present that certificate at the border. We have had several meetings with our partner states and counterparts, and there is a mutual acceptance of certificates on either side. That Ugandans are accepting our certificates and accepting their certificates. And only when we feel that, because surveillance is still going on, and if you have symptoms of this disease, we still take a sample and test you. And for this, we may not allow you to proceed until you get your result. This is why port health officers are there to do surveillance. But we have converted that border now into a testing facility. It is rather pathetic. So the snarl-up need not be there. So as a multi-agency team, the government has worked around this, and trucks have been stopped from moving to the border until the snarl-up has been sorted out. Once it's sorted out, those who are on the journey towards Malaba are being tested before they get to Malaba now. So as they get to Malaba, they're just crossing over and moving on. We have a number of courses that are still testing positive. The question that has been asked here about, are we importing? Most of those that have been tested positive have actually been starting their journeys in Kenya. So you may not say it is an imported disease, and you must admit that local transmission is present and embrace it. And therefore urge drivers, because you know Uganda is not going to let you in if you are positive. So why do you want to risk? There's local transmission here, get tested, be sure, and even as a truck owner, you also need to take responsibility. Let your driver be tested, because if he is not, the truck and the cargo will be delayed at the border, because that driver is not going to proceed to Uganda if he is positive. So it's only fair for the driver and the truck owner to have the test taken before embarking on the journey. And we are urging the truck drivers and the truck owners to obey this. We have developed testing centers along the corridor in Miritini, Mlolongo. We have now one in Maimahiu, so that if you missed a test or if your certificate expires along the way, we are still able to have a test for you and issue a certificate. And this were laid out in the protocols initially, and we are still empowering that, improving on that system and having testing capacities available along the corridor. There was a question on validity of the attestation, and I think we talked about this even last, I think 2 days ago, that we are working on a digital certificate that is going to be again acceptable between our partner states. And we should have rolled this out probably before the end of the week. But we are having a small issue with the linkages of the laboratories, because we want your results to be visible by each partner state, so that there can be indeed a true attestation that that test is valid. And I said we are working on a standardized testing protocol within the member states, so that acceptance, mutual acceptance certificates is actually valid. So the certificate as we are issuing now, and I say just as drivers are able to move across without a valid certificate, Kenyans are Kenyans, and they will probably try it. We have tried to serialize it, and we have issued the authorized signatories of those certificates to those who are supposed to be signing them. But again, as I say, the police officers have this information, so don't try, you may be nabbed. But as I said, Kenyans are Kenyans, and they will try. But we have that system, and hopefully before the end of the week, we should be able to roll out the digital system that has digital information that you can use even a mobile phone to decipher. So moving forward, we hope that issue of validity certificates will be dealt with. There's a question of the budget that, sir, I may not want to deal with the issue of the budget here before the budget is read. I think it's tomorrow. So that will be handled when that has been done. I would want Dr. Nadiri also maybe to clarify more on the various type patients that we have and how they are categorized. Someone asked about how many we have that have in critical care, and maybe Dr. Nadiri can clarify that further. Thank you, sir.
Thank you, Cass. We have 781 patients admitted across our public and private health facilities. Out of the 781, 7 are critical. They are in ICU. 4 are under intubation, and 2 are under ventilation. I think the only thing I would add to that, we have over 85% of our patients leave ICU, and therefore this shows how good and how effective our healthcare workers are in our facilities, and we will continue thanking them for their effort and for all that they are doing. Thank you.
Okay, thank you.
Thank you. I may not give you that figure right away, although we have the statistics. Probably liaise with our communication officer. She will be able to give you at any given time. Thank you.
Thank you again.
Na bila shaka mtazamaji, hiyo ni kamati katika Wizara ya Afya ikiongozwa na Katibu Mratibu katika Wizara ya Afya Daktari Rashid Aman, ambapo kwa sasa wametoa ripoti kuhusiana na maambukizi ya virusi vya corona. Na siku ya leo visa 105 zaidi vimeripotiwa humu nchini, na idadi yote kwa sasa ikifikia, idadi ya maambukizi imefikia 3094, na watu 175 zaidi wamepona kutokana na maambukizi ya virusi vya corona. Na kati ya visa hivyo, visa 18 zaidi vimetokea katika kaunti ya Busia, visa hivi vyote vikiwa vimetokea kwa madereva wale wa masafa marefu. Na vile vile kutokana na idadi ya maambukizi ya virusi vya corona, mtu mmoja zaidi amefariki, hivyo basi kufikisha idadi ya watu waliofariki hadi 89. Na katika kaunti ya Nairobi visa 43 zaidi vimeripotiwa katika kaunti ya Nairobi. Bila shaka mtazamaji, hii imekuwa ni shina la upeo, ambapo tumekuwa tukipeperushia matangazo ya moja kwa moja kutoka katika jumba la afya kuhusiana na maambukizi ya virusi vya corona. Nafahamishwa kwamba muda wangu umekimbia zaidi hapa studioni, na bila shaka sina muda na mie sina la ziada. Ningependa kukutakia jioni njema. Nimekuwa mtangazaji wako Paul Kirobi, na ambaye amekuwa kitafsiri katika lugha ya ishara, nafahamika kama Faith Cheptile. Uwe na jioni njema. Asante sana.